Welcome to Clean Med KE, where we make clinical medicine and surgery clear, structured, and easy to understand. Today, we are decoding the language of voltage to understand cardiac electrophysiology, from the tiny ions moving across cell membranes to the artificial pacemakers that keep hearts beating. Before we begin, a quick medical disclaimer. This presentation is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare professional for clinical decision-making. The heart's rhythm is a masterpiece of electrical engineering. It begins at the SA node, our primary natural pacemaker, which spontaneously fires about 80 times a minute. The signal then hits the AV node, the gatekeeper, which purposefully pauses the signal to allow the atria to finish contracting and fill the ventricles with blood. From there, the impulse travels through the bundle of His, splits down the left and right bundle branches, and finally reaches the Purkinje fibers, which distribute the signal to make the ventricular muscle contract. This entire process is driven by automaticity, meaning these specialized cells generate their own electrical impulses without needing help from the brain. To understand the how, we have to look at ions: sodium, calcium, and potassium. The golden rule is this: a cell's membrane voltage will always chase the resting potential of the ion it is most permeable to at any given moment. Sodium and calcium naturally want to rush in, pulling the voltage toward a positive target. Potassium, however, rushes out, pulling the voltage down toward a negative target. Unlike most cells, pacemaker cells never truly rest. During phase 4, something called the funny channel opens when the voltage gets low. This allows a slow inward leak of sodium, causing the voltage to constantly drift upward toward the firing threshold. This pacemaker potential is the reason your heart keeps beating automatically. Once that drifting voltage hits the negative 40 millivolt threshold, the cell fires. This is phase 0. Voltage-gated calcium channels snap open, and a rapid influx of calcium causes a sharp positive spike in voltage. This is the actual electrical discharge of the pacemaker. To reset the system, the cell enters phase 3. Calcium channels shut and potassium channels open, allowing potassium to rush out. As the cell loses positive charge, the voltage drops back down to negative 60 millivolts. This drop paradoxically triggers the funny channels to open again, looping us back to phase 4 to start the next beat. When you look at the full cycle, it's referred to as a slow action potential because the slope of phase 0 is gradual compared to muscle cells. The most important takeaway here is that there's no true resting potential. The heart is in a constant, beautiful loop of electrical activity. Your nervous system acts as the pedals for this process. The sympathetic nervous system is the gas pedal. It increases the rate of spontaneous depolarization, making the phase 4 slope steeper so you hit the threshold faster, increasing your heart rate. The parasympathetic system is the brake. It makes the slope shallower, taking longer to hit the threshold and slowing the heart down. It is important to distinguish pacemaker cells from the contractile myocytes that do the heavy lifting in the ventricles. Pacemaker cells use calcium for their spike and have an unstable resting potential. Contractile myocytes, however, have a very stable resting potential at negative 90 millivolts and use fast sodium for their initial spike, resulting in a unique 5-phase wave shape. Contractile cells have a special phase 2 plateau where calcium leaking in is perfectly balanced by potassium leaking out. This creates a long absolute refractory period, ensuring the heart muscle completely relaxes and fills with blood before it can contract again. This prevents tetanus, a sustained fatal cramp of the heart. We can see all of this on a clinical ECG. The SA node firing leads to atrial depolarization, which we see as the P wave. The AV node delay creates the flat PR interval. When the Purkinje fibers fire, the ventricles contract, creating the QRS complex. Finally, as the muscle cells repolarize during phase 3, we see the T wave. When the heart's natural conduction fails, we use artificial pacemakers. Single-chamber units are used for SA node issues, while dual-chamber units coordinate the timing between the atria and ventricles. For severe heart failure, biventricular, or CRT units resynchronize the entire heart for better pumping. We also have ICDs, which monitor the heart and can provide a shock if a lethal rhythm occurs. You can identify these devices on an ECG by looking for sharp vertical spikes. A spike before the P wave means the atrium is being paced. A spike before the QRS complex indicates the pacemaker is bypassing the AV node to stimulate the ventricles directly. If you see spikes before both, it's a dual-chamber pacemaker at work. That concludes our deep dive into cardiac electrophysiology. If this helped you decode the language of voltage, please like this video, share it with your colleagues, and subscribe to CleanMed KE for more clear and structured medical education. Thanks for watching.